Great. Well, Chad, thanks for being here, sir. And this has been a really cool topic around social media. I think a lot of folks want to hear more about it. So I appreciate you carving out some time.
Oh, always happy to be here. I'm excited to talk about this.
Cool. So for our listeners, I mean, I'll give a little perspective, at least for my knowledge background, talking about the whole kind of early versus delayed PT and the benefits of that. My understanding of the research really kind of comes from 2004, from Pennington's article in Family Practice through the Arnold article in Archives of Physical Medicine and Rehab that was just published last month. And there's quite a few pieces in that time span. And to kind of even give more perspective, the conversation's changed a lot, because early on, it was all about, being referred from a doc, right? So it was all early versus delayed PT. And then not really considering PT first, because direct access really wasn't widespread enough to have that conversation. But now you look at like Bianca Frogner's work last year, and we're seeing more like, what if you go to PT first as the very first point of provider? And there's other things, are we looking at utilization of healthcare, or are we looking at outcomes? Are we exploring the content of PT? Are we not exploring the content and just looking at timelines? So really this conversation over the past 15 years has been really nuanced, has been kind of all over the map, Chad, and has developed a huge amount of sort of debate. So I guess I would love to kind of open to you and just, what are your thoughts on the whole conversation? Kind of just frame sort of where you're at with it, and then we'll dive into some of the challenges and benefits of different trials and kind of go from there.
Okay. So there is a lot to unpack. I think that, just this, it would be wonderful if we could simplify it and just say going to PT early will lead to lower costs and better outcomes, and everything's fantastic. But it really isn't that clear, because it's going to depend on a lot of issues. Most of the studies that support a PT first domain are going to be observational trials, or they either looked at a database or they've tracked people out over time. They haven't manipulated any of the variables. The clinicians involved were unaware that they were being evaluated on how they managed those patients. And then most of the studies are going to show that you're not going to see a dramatic difference in self-reported outcomes, but it's usually costs or health utilization that decreases, which is still, I think, a big gain with a PT first based approach. And by the way, we say PT first, but this could easily be a different profession first too. Someone who didn't have a higher stake, such as surgery or opioids or something of that nature. We'll throw chiropractic in there, and then other health providers may step up in the future and do the same thing. But with respect to that, the observational trials support it. Randomized control trials, not so much. And usually the outcomes are the same and costs are the same, or and not a big difference with respect to that. But I have some theories why that's the actual case.
Yeah, I mean, Chad, I would love to hear that, because we see all of them. We see the prospective trials, we see the retrospective trials, a handful of RCTs were in that systematic review. I mean, is there a best way to study this? And I mean, where do we go from here? I'd love to hear your thoughts.
Yeah, so my feeling is there's not necessarily a best way to study it. You have to take the totality of information and evaluate that. And the limitations of the design, you have to take those into perspective as well. So let's look at observational trials first.
Okay.
So that's basically, if you look at a database or a snapshot of what actually happened in a real world, who utilized more, who referred people out more, who received more drugs, who had a particular self-reported outcome measure. If we look at those particular findings, then you get a true understanding of what actually happens in the real world, what insurance providers are looking at, what clinicians experience on a day-to-day basis. Obviously, the limitations of that, we don't know the type of patient, whether the nature of the patient is the reason why they ended up with the outcome they did, and the reason why they ended up in PT with lower utilization in the future. None of that was controlled for, and you end up with information that you can't necessarily extrapolate beyond the provider, or you can't necessarily say it's the provider is the reason why you have the outcome. It could be the representation of the patient population or the environment that they're in. Now, the challenge with the randomized control trial is the Hawthorne effect. So, and there are several opioid studies that have looked at this. As soon as they randomize individuals into two groups, and the nature of the study is about opioid utilization, the prescribing physicians change their opioid prescription patterns. They reduce the amount of opioids because they're being watched.
Sure.
And the same thing could occur too if you're looking at utilization rates for imaging or surgery or what have you. Is you get an artificial, and that's one of the challenges with randomized controlled trials, you get an artificial outcome associated with that. So I'm not sure there's a best way. I'm not surprised RCTs are anytime we see a null finding with an RCT, I never get surprised with that. I almost expect it. So I would never expect much out of an RCT with one of these designs.
It's funny to hear that, Chad, because you're kind of growing up, you hear that RCT is, next to the systematic review and meta-analysis of RCTs, you hear RCT as the top of the pyramid. Like, that's what's going to finally give us the answer on which way to go forward is better. Are there other challenges regarding RCT design that you would unpack even beyond just this specific conversation?
There are a lot. The first is external validity, right? This assumption that just because it was an RCT, it's going to work everywhere. We found this, so consequently, it's going to work here and here in this population. To enroll someone in an RCT, unless it's a really wide open pragmatic design, you're going to take a really small portion of the population, and it may or may not represent those actual patients that we see in clinical practice. The big one for me, and I want to talk about fidelity, obviously, and we'll talk about that in a second, but the big one for me is the post-randomization experience. So let's say you randomize people to two groups and you control for the confounding elements of the patient. So the patient's own confounders are controlled by randomizing the individuals into groups. The post-randomization experience is what happens after randomization. And we see this a lot with small manual therapy trials where they compare this technique versus that technique. And maybe somebody has skin in the game for one particular technique versus another, and you see an equipoise problem with that. That can occur also in a randomized clinical trial. You can influence the outcome after the randomization, and it's a lot more prevalent than what we think. The other is what we talked about before, which is the Hawthorne effect. Once the clinicians know they're part of a study in which their behaviors and their treatments are actually analyzed, they do behave differently than what they would in clinical practice. They absolutely behave differently. And that can influence the results of a particular study, probably regressing everything to a common mean. And fidelity is how closely that intervention actually reflects real clinical practice. And that's always a challenge in it. And when you design a clinical trial, you have to be specific enough that you can distill out what the effect of a particular intervention is. And sometimes you sacrifice the intervention approach to capture that, and it may not really represent what you would see in clinical practice.
Chad, when you guys go about exploring any of these topics with your research group, you hear all those limitations and it makes you think, okay, well, there's so much there that you almost don't get a lot out of it. Do you guys look at it and say, look, if we're going to get an answer to this clinical question, we're going to have a variety of different types of studies and then synthesize that data? Is that the idea, since each individually has so many limitations?
You're spot on, Jeff. That's exactly what you do. You contribute to the body of information. I heard Chris Marr say that one time in a letter to the editor. He said, your paper contributes to the body of the totality of the information. And that's all any particular study does.
Yeah.
So you take the whole of it. I really like the way the Oxford group has redesigned their evidence-based pyramid, by the way. There's a new one in which now systematic reviews and meta-analyses are considered only as valuable as the information that is put into it. And instead of it being this, wholly on top of the pyramid thing, it really is detached from the pyramid, and with an understanding that there are certain types of designs to answer selected questions, and sometimes you need more designs to answer one particular question. You have to look at all of the information.
So Chad, going forward, I want to circle back to the PT timeline, efficacy, utilization. What are some thoughts? You were on that article in JAMA that recently came out that showed the 10% reduction in incidence of opioids, as well as, I think, 5 to 10% reduction in overall MMEs. So whether it's incidence or actual utilization long-term, that was very encouraging. Bianca Frogner's 89.4% reduction with PT first was very encouraging. Certainly utilization, at least the way I'm reading the articles, really seems like we're onto something there. Outcomes is more challenging. What are your overall thoughts as you've been tracking all this and contributing to it? I mean, where are we and where do we need to go from here for this research to be useful and change the lives of those that we're trying to serve?
So I'll preface my comment with that I don't know all the answers to this one. I have some theories on this. The first one is I've said this before, I think PT serves as a blocker between a more invasive approach. We block people from surgery. We block people from opioids. At a minimum, we stretch out. I mean, even if we're terrible, we stretch out natural history, and we allow a person to heal within a particular timeline before somebody comes in and intervenes that shouldn't. So I don't have a problem with that whatsoever. I'm a big fan of time. I'm a big fan of watchful waiting. And I'm a really big fan of conservative first point providers who give people options. I also believe that a PT first approach has a certain behavioral component to it. I think we're more apt to give options to patients, to change their lifestyle and expectations, and to build knowledge for them to self-manage. I'm currently in a telemedicine study in which I provide the behavioral intervention over the phone. I have 6 weeks to do this. You build this relationship with the patient. It's like a drip. You just drip the information in, and the aha moment comes in about week 4 when they're like, I can handle this myself. I know what the outcome is going to be. So if I do this, this will be the outcome. I'm good. So I think we have that approach, and that makes a difference in the long-term management and the healthcare utilization. I am a believer. I've worked with Derek Cluley, who's done a lot of health-seeking behavior research. There is a certain behavioral profile to high health seekers. Yes, they tend to be more people with chronic conditions, but if you control for the chronic condition, there is a certain behavioral profile of that person who continues to seek care, who is just a rabid care seeker. They look for every option that they can. And if you can give them self-management strategies, that particular individual is going to seek care less, or they'll accept where they're at. And both of those are victories.
Chad, obviously my mind goes to people that have, a very external locus of control, maybe that are catastrophizing. Were there certain really valid things that we can measure on folks to pick up that it is those individuals who are going to kind of keep seeking care unless we significantly go a different direction and get after some behavior change?
So I'll tell you the one that we captured in Derek's work, and it's in the military database, it's certainly individuals who have higher levels of mental health disorders. And we're talking about cognitions and emotions, and not schizophrenia or things like that, but general cognitions, fears, self-efficacy, coping, strategy problems, all of these things. A second piece, and this harks back to my dissertation work back in the early 2000s, it's also individuals who have high entitlement behaviors. So, and you see these individuals in the far spectrums of insurance domains, right? Individuals who are Medicaid, they actually have high entitlement. They feel like they should receive more care because they're entitled to it. And then Medicare patients actually have higher entitlement than private insurance individuals too, and they commonly seek care at a higher rate than individuals. This is why we have copays and other things to help control for that. But that higher entitlement behavior is another piece that we need to look at. We just don't capture it very well right now.
So the idea being maybe down the road, as we're studying healthcare utilization following maybe our intervention services, maybe teasing some of those confounding variables out, or at least controlling for those.
I see the best thing to me would be to capture this information on intake form where it clusters together and you get some perspective of the behavioral profile of that patient and what you might be dealing with. I've heard Paul Mitkin talk about this. I've heard others, that so many intangibles outside of the direct care that we provide that actually lead to the outcome of the patient. So and a big piece of that is the behavioral piece. And Jeff, you know this, that treating hundreds and thousands of patients, you get some perspective of who that patient is and what that outcome is likely going to be, and what they will plan to do once they finish that PT experience. And I think once we get a better understanding of that piece, it's going to allow us to manage patients even better.
Yeah, absolutely. Yeah, I've been following Derek's work, and it was so interesting, the first articles. I hadn't thought about that at all. And I saw the first one. It's like, boy, if that shows up as being significant, that is a major salient variable in a lot of what we thought we were seeing up until then.
Yep. He was dabbling with his PhD studies on a dry needling randomized control trial. And obviously, it's so difficult to do a good randomized control trial. He would have been 70 years old probably before he would have finished the recruitment of that. And he had the opportunity to work with Dan Ron's MDR database, and I worked with him a good bit. He learned how to code on his own and went in and actually did all the analyses. He really did a splendid job.
That's awesome. So Chad, I guess I don't want to take up your whole afternoon, but where would you love to see things go from here? Speaking specifically about kind of trying to tease out, where should PT be placed in the system, to responsibly balance economics and outcomes. What studies would you love to see be done? Do you want to see, us looking more at utilization? What kind of trials would you love to be seen done? If you had all the time and all the money in the world, and all the manpower, where would you go from here to get a little bit more clarity?
Well, I think, you're a colleague with John Childs, and John's a big fan of systems, right? Of really evaluating systems. I'm a believer that, and this is big, but evaluating systems is probably the direction that we need to go. So I'm part of Stephen George and Nikki Hastings' UH3, and it's research within the VA, and they're looking at two different models of systems of care. So two routes of care for patients with low back pain. In one particular route, it's more of a psychologically informed practice model, where a select group of patients will receive more interventions based on that. And the other process that it's compared against is a pain navigator model, or a navigator model. A person actually navigates an individual's care process. So I like both of those. But to answer your question, it's systems. I think we need to look at systems. And I also think we need to look at helping patients navigate their care possibilities, sticking somebody in front of them that almost has the capabilities of a social worker, of a caseworker, but has the knowledge of a physical therapist, who can say, hey, let me give you some perspective on this. This is what you can expect from your particular problem. It generally takes this long. You should only consider imaging if this. Surgery is only in maybe 5% of the individuals, and it's only if this occurs. Painting that picture for the patient first and seeing how that influences downstream costs. I think that is really imperative. I'd like to see that.
Yeah, that's fascinating, Chad. I'm in a lot of industry, so we're out here with these populations of people, and we often talk about the Choose Wisely campaign and just get them understanding, what tests and measures don't make any sense, for their given condition. And it's amazing the dialogue and the surprise that brings up.
Jeff, it's surprise. In fact, in the telehealth study, that's a piece of what we talk about, how many asymptomatic shoulder tears there are, and the fact that surgery versus no surgery, there's no difference for rotator cuff-related disorders and subacromial impingement. And they are gobsmacked. And at first, there's a disbelief. But again, it's a slow drip, right? You hit them and hit them and hit them with the information, you keep providing with information. And by the end, I think they get it.
Yeah, absolutely. And I really do believe, Chad, that while we've got to work on our systems, an educated consumer is going to be the ultimate solution. Somebody who goes in being aware of, hey, these pathways have greater risk, right? This is too heavy-handed, but someone who's steering their own health, I think ultimately has to be the solution.
100% agree. And almost a lifestyle medicine approach, right? Where they know what, and again, there's a difference between knowing and doing, right? But knowing, most people don't know. I think there's so much misinformation out there. There's in selected groups who do such a better job of profiling what they do than what we've had the capacity to do. So I'm with you there.
Yeah, it was so great, like to see the Lancet series circulated so widely across all social mediums, not just professionals, but everybody talking about a bit more of a common sense not over medicalized, a little bit less dramatic and de-escalated version of going about back pain.
That is exactly right. That's a great example of how the tide has turned and the expectations have turned, and the knowledge now has shifted in that direction more so than we should think about surgery first, and then all these other things are fringe pieces. So, yeah.
Absolutely. Well, Chad, thank you so much. This has been a great conversation. I appreciate your insight as always, and I'll probably tap you for more of these going forward to pick your brain to straighten me and others out.
That's kind of you, Jeff. And thanks for doing this. I always enjoy listening to you. So appreciate it.
Absolutely. Thanks, Chad. See ya.